Hello, I'm Deborah Chieli, a nationally board certified nurse practitioner with specialty certification in lifestyle medicine.
And I'm Susie Spell, a nationally board certified nurse practitioner, also certified in lifestyle medicine.
The following interview was part of a series that informed our presentation at the 2023 Annual Conference of the American College of Lifestyle Medicine, ACLM, titled Nurses in Action, How Nurses Operationalize Lifestyle Medicine in Modern Settings, and You Can Too.
In this series, nurses from diverse backgrounds and practice settings and their champions tell their personal and professional stories about discovering lifestyle medicine and how they're implementing it across a wide range of settings.
Nurses are the largest health profession in the United States and globally and have been voted the most trusted profession here in the U.S. for over 20 years. Learning about and incorporating the pillars of lifestyle medicine fosters full scope of practice and the ability to answer the call to lead by the National Academy of Medicine with their report, Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity.
We hope these stories of success will inspire conversation and drive creative solutions to better address inequities in healthcare. Continued growth of nursing expertise in lifestyle medicine will expedite our nation's ability to address the public health emergency of chronic lifestyle diseases we currently face.
The power of nurses to create innovative solutions when combined with the practice of lifestyle medicine allows nurses to express their full potential while simultaneously addressing the salient issues of health equity, the epidemic of chronic disease, and the provision of truly patient-centered whole-person care.
When nurses are empowered to lead with an interdisciplinary and multi-sector practice, they answer the call of the National Academy of Medicine to dissolve barriers to care and improve health for themselves, the nation, and every global citizen. Enjoy the interview. Today, we have an extra special guest with us. I cannot possibly encompass all that this guest has accomplished in her career in nursing. And this little intro is just going to be the tip of the iceberg, but I hope it's a nice little introduction. So, Dr. Alicia Georges is a recently retired professor and chairperson of the Department of Nursing at CUNY's Lehman College in the Bronx, New York. And CUNY, if you don't know, means the City University of New York, CUNY. And the Lehman College of Nursing has consistently ranked in the top of our nation's colleges in propelling students from low socioeconomic backgrounds into the middle class, which really means that the college helps provide a pathway to not only economic stability, but also economic mobility as well. In addition to her esteemed career as an educator, Dr. Georges continues to be a passionate leader and a community activist. And just to give you a little hint of the caliber of guest that we have today, in 2019, she was named a living legend by the American Academy of Nursing. During her time at CUNY, Dr. Georges played an integral role in elevating opportunities within nursing education for African American and Hispanic and other racially underrepresented students. Being in New York City, she and her students, and I'm sure her colleagues, were witness to the devastation that COVID-19 and that pandemic brought to their city and to all of the country and the globe, really. And that only serve to highlight the existing health inequities in our country's citizens, as well as the inequalities within the healthcare system itself. So my colleague Deborah and I first learned of Dr. Georges while we were researching some commentary about the recent Future of Nursing 2020 to 2030 report, where we were so moved by her passionate statements during that webinar hosted by Columbia University, and we'll link it up. But she started her session with this quote: "We need to become disruptive. We need to disrupt nursing curricula in our country. And disruption doesn't mean we need to march. It does not mean we need to become antagonists. It means that we need to take advantage of the opportunities available, and we must face head on the challenges." And I loved that quote, that opening, and just caught me right from the get-go. And one of those challenges is that the accrediting bodies for nursing curricula need to start incorporating measures of social justice and inclusion and diversity among the nursing curriculum. And in our conversation today, I hope we're going to highlight and focus on some diversity and inclusion kind of issues, social determinants of health, and how your career and your experience can really help us understand this issue a little bit better. So thank you so much, Dr. Georges, for being with us. I'm really floored that you said yes to our interview, and I'm so grateful that you're here.
Thank you for that wonderful introduction. Sometimes you say things and you forget what you said, but that I remember distinctly because a reporter called me after to try for me to explain what I meant by disruptions. I said, I'm not marching anyway. I did that in the 60s as a college student. But one of the key things is that I've been fortunate, I should say, in my career trajectory, in my journey through nursing. Let me just assure you, it has not been easy. I said the past is prologue. And so we have to learn from the past what we need to do in the future. I've learned, having been a student in the Northeast at Seton Hall University in the 60s, and then saw what happened throughout this country. I have to preface that with saying to you, I was not born in what we call the continental United States. I come from the United States Virgin Islands, the island of St. Thomas. So coming to the U.S. and for the first time and being exposed to what was segregation, even in the Northeast, and discrimination, knocked me for a loop. I say this to everybody, and I will continue to say it. There were a group of women, white women, and one black woman in my class. And today, all these years later, we remained close because all of us, even though they may not have been the victims of discriminatory practices, were incensed about inequities and the lack of social justice for our patients, because we saw it exemplified in the care that patients were not given in Newark, New Jersey, in Jersey City, New Jersey. It's been a long journey around looking at we call them public health issues and we laugh now, my colleagues and I laugh. We said, everybody talking about social determinants. We knew that back in the 60s. We called it a whole lot of other things, but it was the same thing. How can we assure that those people that we are caring for every day, help them to live their best lives? And that was critical. And that's why my friends and I, we still act like we're back in college when we meet at any event. People say, oh, there they go, the rowdy class. It's because we have never wavered from that. We've never wavered from that. And I saw that in the careers of my classmates who worked in public institutions and private institutions, and their drive for diversity and inclusion in those colleges and schools of nursing and in the practice setting. Today I laugh and I smile because I see some young PhDs and masters prepared APRNs who some of my colleagues have taught because they've been committed to what it is. So it's been a long journey, but it's not been too bad. I've survived it. I wish I didn't have to go through some of the things, but I learned.
And so what do you think the future should look like? Or before we even get to the future, maybe we could start with where we are now in terms of nursing education and the diversity that exists or doesn't exist in nursing education, and how we could maybe address that.
I was president of the National Black Nurses Association. And back in 1988, I started what we call Black Nurses Day on the Hill. And fast forward 35 years later, and I spoke to the group of nurses gathered. There were so many. When we did it back in 1988, I think the reporters outnumbered us who were the Congress people and the nurses in the room. But now, 35 years later, I said to the group, we may have made progress, but we still have not gotten where we need to be. Black nurses are still a small part of the 3-point-something million, almost 4 million. When we say that many people, I say, listen, there are a bunch of folks ain't coming back to work. So they get counted, but they're not coming back to work. They have no intentions of working. But we are still, less than 7-point-some%? Hasn't been in 35 years. There hasn't been that big an increase. And we see others, and Hispanics are worse off. We see them as the fastest growing population in this country, and yet not represented in any other health professions, to be honest with you. Just like blacks are not represented in nursing or any other medicine, dentistry, pharmacy, etc. And so we've made progress, but we can't stop. We can't be contented. We have got to stand up and say, this is not right. It is not right at this point in time when you read or you listen, as I did last week at the National Black Nurses Conference in, where were we, Atlanta, and sat there in a listening session when Dr. Ernest Grant and Dr. Romay Alexander and Ms. Cheryl Thompson from ANA listened to what the Black nurses had to say about racism and how they've been feeling. And I said to both Dr. Romay Alexander and Ms. Thompson after I said, I didn't go there to speak. I went there to listen. And I said, my God, I feel like I'm back in the 60s. The issues that people were having around promotion in practice settings, issues people were having around tenure and promotion in universities are still alive and well. We've got some programs, we've got some changes, we've got some pioneers, and we've got some go-getters out here who want to do something. And they're not all black. They're not all Hispanic. Most of them are white, to be honest with you, who are driving the fight many times in trying to make sure that the diversity and inclusivity is occurring. Because again, they're committed to what needs to be done. Nursing is human caring. And if we care about humans, we got to make sure we treat everybody the way we would like to be treated. So we still have a lot of work to do. And schools of nursing, people say, oh, but you got a black dean, Dr. Wade at Georgetown, and you got a new black dean, Dr. Amar at NYU. I said, and how many schools of nursing we got? But when you think about, look at how many schools of nursing we have across the country. We find the black deans in the historically black schools of nursing. And that's one of the things that we have not paid as much attention to in this country. They produce so many black nurses. They are pretty much baccalaureate programs. There's some that may have dual associate and BS. Some of them have PhD programs, Southern, Hampton, and they produce leaders in nursing. But they're not funded. I was just and I shouldn't say that, but I was at a policy conference in Mississippi with a number of congressional people this past weekend. They're not funded as they should be. They've got a number of money poured in these last few years, but that's trying to play catch up. And look at who they've produced. They've produced a number of the giants that we have in nursing. I know my mentor, who's now deceased, Dr. Rita Duma. Dr. Duma was a graduate of Dillon, historically black school of nursing, and went on to be the dean at Michigan, University of Michigan, deputy director of the National Institutes of Mental Health. Those folks who were there because they got the grounding. And so we need to pay attention to that. And we need to stop this nonsense that I'm in practice, I'm in research, I'm in education. That is nonsense. We're all in the same fight because the outcome for every one of us is quality care. I call it culturally and linguistically competent care for all patients, regardless of what they look like, who they love, whatever. That's who we've got to take care of. And so we've got to do some right here and now. I see Secretary Becerra was on people saying, "Oh, Alicia, one of my physician friends, you got $100 million." I say $100 million for nursing education is nothing. It's nothing. That's like a drop in the sand, a sand drop, and thinking you're gonna fill up the beach. That's nonsense. It's nonsense. We should have much more money for nursing education. We're hurting in all these places across this country. Why aren't we not just getting it from the feds? Why aren't municipalities and states where they have some dire nursing shortages? Why aren't they out there fighting to make sure that folks get into nursing? You can't tell me that they don't want to get into nursing. I know when I chaired the department, the number of applications we got, we admitted 36%, a third of the people who were qualified to get in, because we didn't have anybody to teach them. We had no resources.
What would it take to make that happen, to get that funding?
Collectives. We think we got to fight by ourselves. Why aren't we looking at the people who make a difference? Why aren't we stretching and pushing more for community engagement? The community help you fight. When I had my battles, that's a whole other thing. When I've had my battles with universities and other folks, I went to the community folks, to the elected officials, the appointed officials, the NGOs, the folks who their mama or their papa or their daughter, their son needed nursing. And they came. In AARP, people say, why is AARP fighting for nursing? Because 50 plus people drive this country. And people need folks to take care of them. That's why there's a Center to Champion Nursing in America at AARP. And when I was president of AARP, people says, why is AARP? I said, you look at my age and look at the rest of you. We are going to need nursing care, whether it's in a hospital or community. We're going to need, like, when you think about lifestyle medicine, we need the people who know and understand what it is to keep the body intact, to keep our minds intact, our spiritual being together. I think that's us. I know it's not, I think. I know that's us. And I don't think about it. It's us. And so we need to make sure that we have those people. I don't care what they look like. I would like more that look like me, but we got to make sure they're committed to that. And we got to do something, but we can't do it thinking that, nursing, and we're going to fight for nursing, and we're going to fight, and we're going to fight the docs. We need to be fighting anybody. We need to be fighting together because all of us are losing out.
Yes. Wow. You're so passionate. I love it. Deborah, I know you're probably chomping at the bit. Do you have something, Deborah, that you wanted to jump in with? Deborah's very passionate about bringing us back to our roots of nursing.
Oh, yeah.
And really tapping into that place, which I also love, but she's particularly skilled at it.
Mm-hmm.
Thank you for that kind introduction, Susie. Dr. George, we as nurses, this is who we are, is we address the whole person. Our code calls us to address social determinants of health. The last line of our nursing code of ethics says nurses are called to heal the world. And when we look at our legacy leaders, we healed not through pills and potions and procedures, but we healed through clean bandages and waters. And you mentioned caring. That's so important. We have a body of theory that informs nursing practice, a body of theory unlike any other. It's so rich. I'm wondering, with all that you shared with us thus far, what you would say. I think we're really curious. We're searching for our presentation to ground it. We have 1 hour in front of providers, practitioners, leaders from healthcare and from institutions in this arena across the country at ACLM in Denver. And we're really inspired by the Future of Nursing 2020-2030, what its call is. Not to say, nurses, you need to do even more, as if nurses already aren't doing enough. But no, all of you need to support nurses so that they can lead, so that they can do what nurses are uniquely qualified, trained, and have the paradigm to do, which is assess and treat the whole person. All places from First Nation health clinics to HIV clinics to acute care settings to infusion centers, all of it, nurses are there and more contact with our patients, the most trusted profession. Given all of that, Dr. Georges, we have a body of nurses who are more and more being educated in the power of lifestyle, coming back actually to our roots, because the pillars of lifestyle, physical activity, healthy diet, all of that are written right into our code of ethics. We're hoping to synergize that, to bring that all together along with the new essentials of the nursing education to figure out how do we bring these communities together. You've spoken to us about that in this time together already. You've talked about bringing communities together, the collective. Could you share with us how you see all of that intersecting? How can we make 1+1, the lifestyle nurses, the inspiration of the future of nursing, and all of the leaders there, the educators, and that are weaving in and revamping curriculum to address the essentials, which calls to nurses back to the roots of social determinants of health. How can we do this? You are a leader. You are talking to us about being disruptive. How do we disrupt this? How do we bring this to the next level of energy and synergy?
First of all, that was I think you've said it, but here's what I see. When you talk about the roots of nursing, nursing did not start in acute care facilities. Nursing was community-based. That's where the problems emerge. That's where the problems have to be solved. Not in our acute care hospitals, not in our nursing homes, not in our clinics and specialty units. So we have got to figure out how we can get nurses to stop thinking that they need a building called an institution for them to do what needs to be done. And bring nurses to tables all over this country where we can get back to talking about what it is that's critical to move our country and our healthcare systems forward and to increase the quality of life for so many people in our communities. So one of the things I say to folks is, I shouldn't say, let's stop having all these conferences where we're talking at each other, and let's begin to create collectives, groups of people around certain issues, particularly around social determinants. What about our schools? Where are the nurses? School nurses have been vilified, have been beaten up, have been pulled apart because they don't have them in the schools. Or they got them running, like in my city, to 5 different schools. But you can't have healthy communities unless you have healthy children. You can't have healthy schools unless you have healthy children. So why aren't we there fighting for the school nurses? Why aren't we coming together in these collectives that we can have? I think we need to be sure to tell people that the basis, the infrastructure on which nursing sits is caring. I don't care which theorists you use, they all are the same around caring. That's the basis that cuts across. And I think on whether nurses are APRNs, whether they're associate degrees, whether they're baccalaureate, master's, PhD, EdD, all the credentials, they care. Otherwise, they won't be there. And so I would like to see us, and maybe your forum is a good one because it talks about the things that are the roots of, I think, what our profession is. And it takes us back to those things. If we want to be physically fit, what about the communities we live in? Okay. If we want to have healthier bodies and food, what about the places that have food or don't have food, deserts, etc. All the pieces that we put together as social determinants. What about the political systems? Who goes out and votes? Who gets them out there to vote so that we can have those 2 things I just mentioned before? What about jobs for people in communities? Those are the roots. Those are the things that we need to be talking about, that then will give communities and people, put them in better physical health. It will give them the opportunities so that they have the correct foods to eat. We also have to think of how we engage whatever you wanted, the church, the mosque, the synagogue, the Quaker house, whatever you want. Or if you're a non-believer, just to talk about what it means to have a spirituality around you. Where is that? And why aren't we in nursing education insisting on that? And why are we so hell-bent on students learning how to start an IV and how to operate a machine? I say I can operate any machine because I know how to read. And I know what I don't know. So I know when to stay out of something that I may cause a problem. But what are we teaching them about the whole issue of human caring? About what people's needs are physically, mentally, spiritually? How much, I'm so sick of us doing, well, we got psych nursing, then we got, maternity, then we got peds, and then we got med surg, and we got medicine, then surgery. And what is the biggest miss? Is community. We miss community once again because we miss where the issues are. How do we integrate that? And how do we bring people back to where we started? Where Florence Nightingale started, in the community, where everybody else, where Lillian Wald. If you want to talk about a champion who did, I worked for Visiting Nurse Service for 10 years. I have to talk about Lillian Wald. How did, a person who was the epitome of what you're talking about, looking at people's root, looking at the roots, looking at lifestyle, looking at what people need, particularly with the child health stations, the milk, the living conditions. Look at Margaret Sanger. I don't care about people's religious beliefs, but look at what Margaret Sanger did for women. Those are the people and those are the roots we need to. When you mention Lillian Wall and Margaret Sanger and some of the students don't know who you're talking about. They have no idea. No idea, who you're talking about. And it's not just talking about those folks, but as I said, the past is prologue. We need to bring those principles, kicking. That's why I'm talking about disruption. If we got to disrupt the curricula that we have, we need to say we are not going to do it. I say that to Deborah Troutman. She just looks at me and she's a good colleague. But I don't think they don't measure anything. CCNE does not measure whether or not we teach anything about social justice and equity. None. They don't care if your school is diverse. You just give them the demographic data. Do they say what happens? Where all they? If you're in the Bronx, where's all this? Where's all of that? They don't ask those questions. They don't ask the questions about faculty. Where's your faculty? That's not what that comes up. We got to disrupt that stuff. We got to stop that. We got to tell people we are not having this anymore. We want a different. Now, don't misunderstand me. I'm not going to go back to the way we taught 100 years ago. But we can't throw out what we did learn. But rather, we got to bring it forward in this. And one of my colleagues said to me, I was talking about something. And he said to me over the weekend, he said, they got AI, so maybe now people realize what's going on. They could put a word in and maybe in AI, they'll figure out what they need to be doing. I said, Lord help us. He said it, but we can't, I didn't want to dismiss it. He's right. We've got all this innovation. We have all this technology. How are we going to use it to the best of our ability? Who's going to be left behind? Nobody should be left behind with AI. Nobody. But maybe AI can help with the whole lifestyle medicine piece. Okay? We can't dismiss it. Because as we see the younger generation who you now want to begin to help mold so that when they're my age, at 79, that they can at least say they've lived a good life, that we got to start early. So maybe that'll be helpful for you because maybe they can do it and go in and pull down more things than we can get at a time. Maybe we need to really look at how we integrate that into what we're teaching in the schools, not for them to write a paper and hand it in to you for a grade, but rather what we can do, how we can form things, develop things. It's just some thoughts that are swimming around in my head.
Yeah, almost.
I don't know if I answered your question, but
It seems what you're talking about is being very experiential for sure, right?
mm-hmm.
I loved my community rotation. It was, I loved it.
Me too. That's, but that was back in the 60s. We used to say we carried a bag for a whole semester. We had patients. We went into some of the not the greatest places in New Jersey, but we did it, and we saw the results. And over time, you see how it's so important with communities. Again, I still say we need to bring some new, as AARP would say, new agents of opportunity to the table. And they don't have to be nurses. They don't have to be in healthcare. They need to be the community-based people. And I think you'll get the answers to your question.
Thank you for that, Dr. George. And given one of the points that you made in there was such a key one. In some ways, when we look at how far we've come in nursing, it is amazing what nurses are doing, central lines, all kinds of amazing things. And yet, when most of us graduated from our nursing school and nursing fundamentals with all of these stars in our eyes, and then we went out, and many of us did end up in that acute care setting, and we're running from bedside to bedside with medications and setting wound vacs and wound dressings and all. As you said, number one, care is moving into the community at this point in time. The acute setting is very short window, and now people are being discharged. And also the community is where we can prevent our community from being in the acute care setting. And this was our home. This was where nurses always practiced. Florence Nightingale. One of my favorite pictures, it gives me chills and still I cry for it, is Mary Breckenridge and the frontier nurses on horse.
Mm-hmm. Horseback, yeah.
And I always say, let's saddle up. We've got work to do. But those Lillian Wald climbing
over the tenement. We used to climb over the tenement building to get from one building to the next. Yeah. We won't think of doing it now.
Yes. So those are heroes. And to know that nursing students aren't being informed that way because there's only so much room in the curriculum, and there's IVs and there's central lines and there's all of this that nurses are learning. But what about the nursing roots, the whole person, the nursing history? If we don't remember it, we're destined to not be who we really are. The caring, the theory that informs us. That's all so important, so powerful. I almost feel that in some ways we drank the Kool-Aid. And I love that you tap back into the community. I wonder, with all that nurses are taxed, nurses are still predominantly female, still the mothers in the families. And we know about the situation with the loss of nurses every year, losing nurses, especially after COVID, on the stresses on nursing and the importance of nursing self-care and nursing health. How do you see us doing this? Because nurses are advocates. We're the ones that are the last step between that patient and whatever's happening out there. And then to say, and what we need to do is now be out in the community, forging alliances with the mayor, with city council, with the public health community, with the schools. How would you envision us doing this, and we're really trying to develop assets and action plans coming out of this 1 hour that we get before people, and then an evolving materials and content that is a synergy of the call of the future of nursing and the inspiration of lifestyle. What we know now about, we have more science around the power of lifestyle, prevent, treat, and even reverse disease. We have so many studies still every year more. So now if we put those together, that synergy, how do you see us doing that both on the education front with our young nurses, with our nurses that are in the acute care setting, and our nurses have to be able to pay their bills and the reimbursement for nurses. Many times they're on the cost side of the equation. Can you speak to some of those?
I'm being very transparent. I run a project now at Meharry Medical School, which is in Nashville, Tennessee. And it's a community health workers project. See, I think we need to begin to look at some bridges and some, I call them connectors, for us as nurses, so that we got folks now who can connect us to the people who we need to make sure they're getting the care that's required. So we've got us who are the ones who've got all the knowledge and skills, etc. And then we've got these community-based people, some of them with degrees, etc., but they're of the community. And because they are of the community, they don't have to work hard as some of us would have to if we weren't those community-based people. We need to help them, teach them, guide them, so that they move towards working with those communities that need our expertise as the professional nurses, so that they can open the doors for us. I call them the door openers. They can also be the door stoppers, but they're the door openers for us in communities. And we need to utilize their skills and their knowledge about the community so we could reach the people who need the expertise of all the professional. We use them in primary care to get people to the nurse practitioners. We can use them to get people to the specialty clinics. We can use them to get people to be vaccinated, immunized. We can get them to make sure people know what to buy in the supermarkets. We can get them to help us. We teach them so that they can talk about physical activity. We can help them so they can talk about the mental health issues in community. Do the mental health first aid with them, so that I made all my students one Saturday. We ran out of space, but had them do the mental health first aid, because that's different, because that's a community-based piece, so that we can get them, and then we become the resources for those people. You know, we're not producing the numbers as fast as we should or could, but in the interim, we can use some alternatives. I tell people, don't ever misunderstand me. I'm not talking about replacing the professional registered nurse in this country. On the contrary, I'm talking about enhancing the role by getting some connectors to the communities in many of those where we've got the inequities and the gaping disparities. When you look now at the data that's out about the mental health issues in communities of color, it's depressing. We got it all over, but those are communities that are hard hit. Where are the psych mental health nurses? We ain't got enough of them. The psych mental health practitioners and clinicians are so rare in many communities. But if we can begin to get people to know what the things are that they might pick up, to intervene early and bring the people to the experts, to the ones such as ourselves, I think we can enhance our role, and I think we can make a difference. I'm trying to make a difference. We've got a curricula. There's a whole community health workers curricula, but in where we are, we're using some specific things because of the state of Tennessee and what's needed. I know in New York, we've got community health workers, and some of them are scared they're losing their jobs, but that's because they have them in some of those settings where, you know, they got a lot of money when it was during the pandemic, and now the money's dried up, but the money never got to them. God knows where it went within the system, but it didn't go where it should have gone. But we can tap into those things. I think nurses, I'm all for everybody getting educated, get us there, but we also must not forget that not all nurses going to be APRNs. And we've got to really take a relook at the role of the registered nurse, whether it's inpatient, in clinic, or in community, because those are critical roles. And we don't need, I'm the this and I'm the that. We need this. Less work in making sure I enhance you, enhance me. You refer people to you, refer them to me for the other pieces that we need to get done. When I'm not talking about practitioners, being part of, replacing physicians, although they're misused. I think it's a misuse, using the practitioners in place of the residents because they don't have enough, but there are ways that we can use the skills of the APRN who's in a position to help other nurses and educate them, so they educate another group of people so that they can connect to the community. I know I'm a Pollyanna.
But it sounds to me like it's almost like creating ambassadors in the community. And I feel like nursing and caring in general has that ripple effect. That's what I want to do, is have a ripple effect that I teach you, and you get your own success and you teach somebody else, and it ripples out to your family and your community and everyone that you come in contact with.
But the other thing that I tell folks that we must have is we must have the data to support everything that we're doing, and we must have the data so people can see the before, the during, and the after, so that we've got to do this in a systematic and use the science. We need to use technology. During the pandemic, I had a group of registered nurses that were teaching. Well, it was the online group anyway. They've always been online. And I was like stunned. One of the nurses created a group that on Facebook for mothers in her community who had children who had some issues around developmental challenges. It was a Facebook, and they continued it. Those are the kinds of technology we can use. Black folks all got a smartphone. People don't have house phones. How do you utilize this to help people? I went on that healthy nurse thing. I still do it. And I'll get alerts. Don't forget to drink enough water today. You can replace your water with tea. Why aren't we utilizing that more when we're talking about lifestyle medicine? That's a great way to do it. How many steps did you go today? I don't have on my Apple Watch, but I know, and I said, oh God, I didn't do my steps today. Maybe I'll walk around and around till I get my steps in. But hey, I'm doing it. Things like, did you eat at least 2 pieces of fruit, whether it's a cup of juice or whatever? Those are the kinds of lifestyle things that folks can use. What we've been using it for, that many of the people have used it in some of the funded projects from particularly NIH, is they've been using it in treatment stuff. So like they'll send the high blood pressure. Did you take your medication today? I said, they shouldn't just be saying, did you take your medication? Did you do some mindfulness? Did you meditate today? Did you walk? Did you drink enough water? Did you take time off and turn the TV off and close your eyes for 5 minutes? Those are the things that we can use the technology and the innovation. And I think the best people to do that are us in nursing who know the things that need to be done. Now we just got to find the money and the wherewithal to get it done. But and the money's out there. There's some young IT people and folks. I'm not an IT person. I use every device I could think of. I got 2, 3 computers that I use, plus an iPad, plus my phone. But I think I think you folks in lifestyle medicine, those are some things I'm sure you're using and can really build on that to change behavior.
And the technology, Dr. Georges, is the picture of lifestyle medicine, integrating technology, leveraging the team. Could you tell us a little bit more about your project there in Tennessee? That sounds amazing.
It's a HRSA-funded project. The United States government funds it because HRSA, Health Resources Services Administration, realizes that there are not enough nurses out here and that we're not reaching the people who need to be reached in communities across the country, that we're not doing a good job at decreasing the disparities, that we've got to do something. And so during the pandemic, I think the feds got a rude awakening that it was the community-based programs, the people who were in the community who got people to go get vaccinated. Our nurses were so busy working, trying to save lives in hospitals, that it was the professional organizations out here where if they weren't working, they were out here trying to get communities to get vaccinated. But a lot of what happened didn't happen with health groups. It happened with many of the community-based organizations. And the role of the community health worker has always been paramount throughout the world. When you look at the continent of Africa, that's who many of the folks who are delivering care. They may not be nurses. They're not going to go and deliver babies unless it's an emergency, but they don't have the people either, and they're using that. So we're hoping at the end of the project to have had 240 people, and some of those folks we're doing some upscaling, and there's a number of other modules and stuff we're going to be developing to help them to increase their skills in community. And I, for one, want some of them to go to nursing or PT or OT or whatever to increase those professions, and get credentialed, and then bring on groups. So it's something that we don't have enough data. We haven't even completed our first year yet, so we're working on the goals and where we are in getting this stuff done. We as soon as we get we're collecting our data, we're going to make sure everybody in the world knows it, because I think it's so important.
To follow up on that, it sounds like when you talk about community and collectives and door openers, you're speaking to people like the community workers that nurses could train and work with and help lead a clinic or an effort in a community. And then the people that are in positions of power in the government or in agencies, NGOs, things like that, that can open doors, provide funding. So on both levels, people don't have the BSN RN and teaching them. We're talking about very basic things, knocking on doors or having blood pressure clinics and talking about vegetables and fruits and finding out what people need. And then on the other hand, connecting with people that are caring in the community, have resources, are connected to other resources, and can support this. And it sounds as though nurses could be in the center of much of that.
I don't know if you've seen the Hopkins. It was originally funded by AARP Foundation. The Hopkins model called Capable. And when I was president of AARP, I always touted it as one of the great models for people to think about. One of the things, that's a nurse, social work, and I call them a maintenance, not a maintenance, but somebody who does maintenance and keep things going. And it was developed by the now dean at Hopkins. And they make visits to homes in older adults, public housing, where they go in to be sure that it's a safe environment. And if there's something that needs the nurse is there because of all the medical health kinds of issues, the social worker to tap into what else is going on that the person may need for resources, and the maintenance person to make sure they don't have loose anything on the floor, something where they may trip, leaky faucets where it may drip, those kinds of things that and it's scientifically based, it's got the evidence, the data are there. And that's what I say to people: when we create these models, we've got to have it really tight with evidence, data, and the science. Otherwise, nobody's going to pay any attention to us, and nobody's going to fund it. So that's why it's so important to have the information. But that's an excellent program. There's been other models across the country. A long time ago, Linda Burns Bolton, who used to be the chief nurse at Cedars-Sinai, and I wrote an article on the National Black Nurses Community Collaboration Model, where we talked about, and we use Becker as a scientific infrastructure and how things could, Becker's model as a public health model, and use that because we wanted to make sure that people knew. Again, that's why we talk about the collectives, to bring in people together, how you utilize the folks, what do you do with them. It's an old model. I'm trying to remember, it was in the 90s when we wrote it, but now I keep seeing in my research gate or something in a citation, your model was cited. I said, oh my God, people are still reading it, because you know what? It's come back around for what needs to be done. The things that you're doing, it comes back around for where we need to really do community engagement, and how do we form those collectives so that we can get the work done.
Thank you. Susie, would you? I'm sure you have lots of questions.
I just love what she was saying. And to be honest, I don't know the Capable model. I'm gonna look at it. I think a lot of what you shared with us today is a lot of food for thought for us to be able to go and
Mhm.
look at some of this and see how we can integrate that into what we're doing, because it's
Mhm.
so important. Like you said at the beginning, things start in the community, right? And that's where our problems start, and that's where we can be incredibly powerful. I have some things to look up, and I'm really looking forward to what happens with your project in Nashville. That will be a great thing to look at as well.
It's for the whole state of
Oh,
Tennessee. Yeah,
Tennessee, the
yeah,
whole
we're
state.
doing the
Oh,
whole
good,
state. Mhm.
good. And so, how many people are a part of that?
I'm now on the faculty of the Division of Family and Community Medicine. So it's a family and community medicine. They don't have a nursing
Oh, I
program.
see.
But they want those, Dr. Frida Outlaw and I are the two nurses who are leading
Oh, good,
the project.
good.
And Dr. Outlaw is a psych mental health nurse who used to be the deputy commissioner of mental health for the entire state of Tennessee.
Wow.
So I'm in New York, she's there, but we intersect, we meet. I was on a meeting with them earlier today, and yesterday. So it's,
Yeah.
because we're both committed to
Right.
it.
Sounds like it. It sounds like you've been very committed for a long time.
Yeah, it's just my father used to say that service to mankind is what you have to be, and that's the way my family, and so that's the way I grew up. Everybody did something. People always say, "Oh, their family, they either this or they're that." It's not. We don't go to. It's just it just became part of your life. You just did
Right.
it. Yeah.
So, just one last question. Well, actually, it's two, but what would be your advice? I know you've given us a lot of advice already, but any advice for nursing educators out there? Or if you had a magic wand, what would be the next thing that you would magically make happen?
One, I bring in more practice people into the education system. There are too many people in nursing education who forgot what it is to be nursing. I shouldn't say that, but it's true. Okay. And so we need to we talk about this over and over for years, and there's so many models. We have got to do a better job of binding nursing practice, research, and education together. We have got to stop this silo mentality and the hostility that I see generated between education and practice sometimes. And so that I will call on healthcare CEOs and stuff to let your people participate in nursing education programs that are university and academic center based. All these barriers, you can't have somebody who works on the floor working for you in the same house. I said, what is that foolishness? I said, that's what I talk about disruption. I said, that's nonsense. I want the people who understand how the floor operates so that the students can have an easier thing. I said, so having them come in to your nurse internship program is nonsense because it is separate. Then it's during the summer and has nothing to do with what they're learning in the programs. So I like to see that happen. I want us to really I think in some places, we have got to stop and make a much more concerted effort to do that. Otherwise, the future of nursing 2030 ain't gonna work. All right. And in doing that, we have got to have nurses speak up, talk back with respect, and make sure they get to those tables. And where they have to be, nurses have got to make sure that they're there when those policies are being made. Not going out on a picket line 5 years later, but saying, no, we will not work extra hours because we're ineffective and use the data to support it. We will make too many mistakes. We have got to do these things. We will not do this. We don't want to be the group of no's, saying no's, but we've got to come with alternatives. And I think this is where the research, our nurse scientists, our nurse educators who are also nurse scientists, our practice people can really come together. Otherwise, this future nursing ain't gonna work. It's not gonna work. I'm here to tell you it's not gonna work. We're not gonna get rid of inequities. We gotta start with dissipating the inequities that exist in our institutions right now before we worry about doing it in places. All of us need to be on the same level playing field. You can't have the one up and the one down in nursing and then saying, oh, we'll look out for you later. Heck no. We got to do it now. So that's I said what my mother used to say, you clean your own house before you go telling anybody else to clean theirs. That's what we need to do. But I would like to see us, and that's what still troubles me so much, that we haven't. I've tried it. I've created models, and then somebody come behind you and dismantle it. So we've got to make it the infrastructure, that it's not dependent on the two of you and me, but rather on what the outcome should be, a solid infrastructure to create those models.
I love everything that you've said. You've been so passionate, and I really appreciate your willingness to spend your time with us today and for sharing your wisdom so passionately. I love listening to somebody like you because it gets me fired up too.
Listen, you're fired up. That's why you're already doing what you're doing. You're already there. You're already there. You're passionate about what you're doing.
Yes, that's true.
And I admire you for that. I admire you for that.
Thank you. Yeah. Deborah, anything else from you?
Oh gosh, I would love to talk for another couple of hours here. I think one of the things I'd love to touch on is our nurses that are and Susie and I want you to know our passion is really about our BSN nurses also yes, as advanced practice nurses, we have the ability to write prescriptions just like a physician does. But we know that these BSN nurses are numerous. They're idealistic about their desire to help and to care. And they go out there and they are hit in the face with a healthcare system that is really different from what is in the textbooks, why they got into nursing, about caring. And you've touched on so many ways that we need to change the system to empower these nurses. I wonder, to circle back to one of the things that you said about technology, all of them are coming in with a lot of technology. I wonder if we can imagine for a minute something that we would be able to give them to also, one of the things that I do is I ask my nurses, I teach at the master's level, just part adjunct faculty, advanced patho, and I weave into the curriculum about lifestyle as medicine and also the code of ethics. And I find that as I've started to do that more and more, I'm in my third year, the students get on fire about this and they are so inspired by it. And also about our code of ethics and the legacy leaders that we were talking about, Lillian Wald and all. I wonder, can you imagine, because you shared with us all the technology that you have and you really embrace it in AI. Do you have any ideas around that? Because that really lit a fire in my heart about that, almost like bringing these legacy leaders to life for real to tell the story of nursing. Because I can share that when I pick up my blue code of ethics of nursing, I get chills and I'm so inspired. And yet I see our nursing, because we're learning about all these other things and the curriculum is so packed, that nurses are not getting copies of it. They're not reading it. They don't know the power of what's in there about addressing social disparities, social determinants of health and disparities. It's written right into our code, and the lifestyle that's written right into our code. I wonder anything else when we ask you what you would imagine or change or do, anything along those lines that we can, as we look into the future. We've talked about going back and remembering our roots, so important. I think that we've in some ways forgotten ourselves because we go out there, and not that nurses aren't doing great things, but also there's all of that as many of the docs are able to embrace. One doctor that I'm familiar with, Dr. Ted Barnard, he says, I'm the high-tech doctor with low-tech solutions. And then Dr. Dean Ornish brags about these simple things. And so for us as nurses, it's like we've arrived to be able to immerse ourselves in all of this technology and medications and putting in central lines and all. And yet what will really heal the individual, the community, the family, the world, and in fact, what we're facing right now with the existential threat of climate change. And we are positioned to address that. Nurses are called to heal the world in our code. I'd love to just ask if you have a few minutes to speak to all of this, because it is really where we are right now. Is we're on the cusp of nurses doing such amazing things, and yet the really powerful things, the most important things are, how do we help neighborhoods be safe so that the person can walk, access to healthy food, the behavioral health interventions that you're talking about with the epidemic of loneliness. And
I think if we want to use technology, I think we've got to take simulation up much higher. And we got to create real situations, not these artificial things that we've got to create real life situations. And maybe we need to bring in real live people. I don't know. We've used standardized patients in the past, but we can create scenarios and have students, at least for my years at Lehman College, where we're the worst borough in the entire state of New York. We're number 62 of 62 counties, meaning we have the worst health indices in the entire state. And I told the politicians that we need to stop saying that, because that's what we're going around saying, oh, we're the worst. We haven't done anything in all the years, So how do you get a student, a BS student, to understand? Yes, they want to make sure they know that you got to listen to the abdominal. You got to listen before you touch. You got to do this. You got to do that. But what else do you do with that patient? How do you talk to that patient? How do you determine what their literacy level is so that you can teach them? How do you find out from them, what goes on? I had to do a pre-check for a visit to the pain management folks. I have a trigeminal problem. So they ask you all these things. It's so sterile. It's so sterile. Are you lonely? Are you in a situation where you need legal assistance? Do you need, and then nobody asked me anything. I just check. No. I said to the NP, I said, did you read what I wrote? She said, oh, it just said you answer the questions. I said, did you read my answers? She said, she was getting furious. She wanted to know who the heck am I to be telling her what to do. We ended up knowing that I knew how all the people who taught her. But I said, you should be asking me, not just depending on because you never looked at it. We need to help our students to learn how to, and I said to them, you can interview without being invasive. But we got to teach them how to do this. We got to understand that if people trust us, we have to create the milieu in any situation to assist the students in how the patients will trust them. But first, they got to trust us, the students. So we've got to create that environment where the students are trusting us, and then we could place them in those situations. I think that we could create, and if I had the wherewithal and the skills like former IT thing to do it, I would create some different kinds of scenarios and simulation and probe. They're saying, don't ask me that question. You're asking me too much. The patients, these simulators are so nice to everybody. We only tell them we got a pain. Well, we can create real life situations, because we can't get every student into those things during their time. But we can create it so when they get faced by it, they're not so taken back. We also have to help our colleagues in practice to help those students when they come to them, to help them to create what's real and stop being mean to them. Okay? You got to stop being mean to the students. And I tell any of my former students, why are you so mean to the student? Do you remember what you went through? So we got to create that whole practice to trust us to test the practice. Don't go in thinking that they don't know as much as we do, those kinds of stuff, but really create those situations. And I think we could do it through technology. I think we can create those things, and we can make people, I sit next to people on the plane, and then I read my Nook. They're watching movies. They're watching videos. Why aren't we doing the same kind of things and then using that in practice? But I don't mean for us to do it just in the institution. Create those scenarios and stuff with our practice partners so that our students, the BS students that I don't worry too much about the NPs. To be honest with you, I think the NPs have got a much better drift on it, our APRNs. I think we need to do that with our BS students so that they're seeing real life things, that we don't create for them these artificial situations where they get one patient and they sit with a patient for 12 hours. But to get them, and also you use the word that team, get them to work in the teams, get them to work with the nurses, get them to see how the nurses got to put up with, what's going on. So they got to go and pick up some supplies if the nurses, they got to, now we have to stop cushioning them and making everything so artificial. So that when they go in and they say, Georges, you got 4 patients today. I'm like, and that's the shock. And we used to have where now people, and it's been expensive for some programs, and some places won't allow us to do it, where the student gets a preceptor and follows them on their shift. I think we need to look at some more of those kinds of settings. But again, we need to prepare them. I think we need to use AI. We need to use I bought my grandson who's 13, these Oculus things. Oh, he loves them because you can create all kinds of things with it. We need to use that. You want to talk about legacy and bringing in stuff? Right in classrooms. My chief lab tech used to say to me, we could bring in right into a big classroom things, beings, a whole body, anything into a room and bring those things right in a discussion, and say these are the principles we've taken forward and connect them. We got all these, I call them sterile syllabi, because that's all they are. You look at all these syllabi across this country, they all look alike pretty much, even though we say we're so different, but we're not. So that we need to bring in, and we need to teach students how to be disruptive, good disruption. We need to teach that. We're not telling them to go out there and we need to teach them, do not tolerate the status quo. We're not teaching it to them. And we're not teaching them, and we need to help them in how they deal with the nurses when they go into practice. That's what I'm talking about, is scenarios to help them to see. The nurse has no right speaking to you like that. Now, how do you handle it? We don't deal with conflict. We shy away from all this conflict that occurs in daily practice. And what we need to do is create those situations where the students then know how to get in a win.
I love that. Get it? Yeah. How to teach you're going to face conflict, how to make it a win, how to deal with that, whether it be with a patient or with colleagues as a nurse. And also our legacy leaders were disruptive. They were really disruptive.
Very much. I mean, they stormed into the governor's office. Lillian Wall grew up with Herbert Lehman. She would walk in his office when he was governor and demanded stuff. I don't know that they let us in there, and they got state police around everybody now. We couldn't get into some of these places, but they were disruptors. I loved it. I loved it.
Dr. Georges, thank you so much for your willingness to meet with us and all the time you've taken with us. I really appreciate it. I know Deborah does too, but thank you so much.
I enjoyed this talking. I'm just fascinated by the two of you and you taking on this lifestyle medicine. I think it's so critical, and and people need to know more about it and to really know what's going on. And you having stuff and your YouTube, I'm going to suggest to folks that they play them and they use them, use as resources for students.
That would be awesome. Yeah. We'll hopefully have our page up where our presentation is at the end of October. So we're hoping to have it live when we do that. So it'll be another little bit, but not too long. We'll let you know.
Great. That's great. That's great.